Welcome to another episode of Global Health Dialogues. Today, I am truly honored to sit with a lady whose leadership has shaped global cancer research and prevention in profound ways. Dr. Elisabete Weiderpass is the director of the International Agency for Research on Cancer, IARC, the cancer research arm of the World Health Organization. Dr. Weiderpass is a medical doctor and one of the most respected cancer epidemiologists with more than 700 scientific publications. I repeat, you heard me right, 700 scientific publications spanning women's cancers, infection-related cancers, lifestyle risks, and global cancer surveillance. She is the first woman ever to lead IARC, that was founded in 1965, making it 54 years old when she assumed the role in 2019. Her leadership has strengthened cancer registries worldwide, advanced prevention science, upheld the rigor of IARC'S monographs, and deepened partnerships with low and middle-income countries. Dr. Elisabete is widely recognized as one of the most influential voices in global cancer prevention and evidence-based cancer control. Dr. Elisabete, welcome to Global Health Dialogues.
Thank you, Dina. It's such an honor to be here with you. I'm really delighted for us to have time to talk together.
Thank you. I'm so glad. Dr. Elisabete, three things I did not know about you and IARC. One, that you are from Brazil, which I didn't know that, and that you and I and IARC were all born in 1965. No wonder certainly you and I get along. We're from the year 1965. What a coincidence. IARC's birth was also the same year. So it's fantastic that we're doing this podcast this year. I have to begin with this. You were the first woman ever to lead IARC, and that is huge and deeply inspiring. And honestly, it speaks volumes about your expertise, your leadership, and your scientific standing. But I also feel a touch of cynicism. Why did it take IARC 54 years, more than half a century, to entrust a woman with its highest role? It can't be that there aren't enough amazing female scientists in the world. And more broadly, what are the invisible barriers that female scientists still face when it comes to leadership, visibility, and real influence in global health and research? And now that you are director, are you now putting systems in place in IARC to promote more females in scientific leadership positions?
Thank you, Dina. You are such an important question and such a sensitive one as well. I think the female role in academia and in research has been lagging behind for decades. As you said, many organizations have zero women in leadership, and many universities still today have just a minority of female as professors and even less as leaders of departments or leaders of universities and so on. Progress is very slow in that sense. The UN is the same, is the image of society, one could say, where the vast majority of leaders are still male. And if you look historically, since the creation of the organization, the United Nations, and all the daughter organizations within it, the absolutely majority is still male. When I look back in the pictures from 1965, from the inauguration of IARC, it was only males. There was not a single female in the official pictures. They are all on my office. The only females were the ones doing the typing, the secretaries. So we have come a long way from that. So when I arrived in office in 2019, yes, I was the first female, and I did feel a huge responsibility to support women in research at all levels, from early career until senior scientist. And today, it's 7 years now that I'm in office. And this year we have reached parity. So we have 50% of the leaders at IARC, meaning at the senior level and above or very senior level, female. It's the first time in 60 years. So it takes time, it takes compromise. And also there are many barriers that we can cite. And one of the barriers is the idea that this is not an issue anymore, that we do not need to pay attention anymore because women are already there. No, they are not. It's still in Europe and in many parts of the world, the salaries of women are lower than the salaries of men. In France, it's at least 20% of equivalent positions, less salary for women across all levels, not only in research. And there is still a minority of women in leadership. So it is very much on the agenda. And I hope it's in the agenda for many countries. We have seen a return to backwards in the political agenda in many parts of the world today, and we don't need to discuss that in detail, which are those countries. Happily, for some countries still have gender parity and the advanced of women in education and in leadership as one of their priorities. And IARC is amongst these organizations that keeps gender parity very, very high up in the agenda.
Fantastic. I mean, really, I cannot believe that even in France and perhaps other countries in Europe, for the same job, a woman is paid less. It's crazy, but you know, we have to talk about this. We have to make people uncomfortable about this to make it go away, because it's crazy. Like I said, it took more than half a century to have a female leader. But there you are, and you've done a lot to forward women's role, certainly in the agency. And that is going to help a lot in showcasing what women can do when they have the opportunity to take up leadership roles. For many listeners, Dr. Elisabeth, IARC is the quiet scientific engine behind global cancer policy. Briefly, please explain to our audience what is IARC's mission, what does it do, and what's its unique role within the WHO family?
Thank you, Dina. So IARC, the abbreviation IARC, stands for International Agency for Research on Cancer of the World Health Organization. We are an independent cancer research institution within the United Nations and WHO system. What that means? That means that this agency, which, as you mentioned, was created in 1965, is composed by countries, by states that opt to join an alliance of countries doing cancer research. Currently, we have 30 member states, which include Canada, the US, 16 countries in Europe, Egypt, Morocco, Saudi Arabia, Qatar, Australia, China, Japan, South Korea, Russia, and Iran. So it's a coalition of countries that want together to advance on cancer research. So what IARC does, we base, our niche is research on cancer prevention, research on cancer registries, on cancer statistics, on prognosis for cancer, and the comparison between countries and what we can learn across the world from different experiences to prevent, to detect early, and to treat early cancer globally.
Thank you so much. Wow, only 30 members. I would have thought you would have more from the global membership of the UN. Is it costly to join as a member?
Yes, there is, as in any club, let's say, there is a fee or a cost that means countries contribute economically to the infrastructure of the organization. Basically, all our projects are externally financed by grants, as in any academic institution. But the basic infrastructure is paid by the member states, and that has a cost. And that, of course, the countries need to opt in to the organization and pay the fee.
Yes, okay, that's great. You, Dr. Elizabeth, you often say no data, no policy. IARC has a long-running global surveillance project, cancer incidence in 5 continents, that CI5, that compiles high-quality cancer registry data from around the world, considered the global atlas of cancer incidence. It enables comparative research across continents, and most importantly, it supports global cancer burden modeling. This is all good and done, but nothing will replace the importance of population-based registries. And I quote you here, you say, population-based cancer registries are the foundation of any national cancer strategies. And yet, while cancer is rising fastest in low and middle income countries, LMICs still have the weakest data systems. Why is that? What are the most urgent gaps you see? Is it training, funding, political will, or infrastructure? Please, can you walk us through what it actually takes to set up a cancer registry? How difficult is it?
Yeah. So first, maybe we should tell our audience what is a cancer registry, because many people might not have that clear. So a
Yes.
cancer registry is basically an administrative and research database where in a defined geographical region, let's say a city or a state, all cases or incident cancer cases which have a confirmed diagnosis are registered. You have usually the name of the person or the ID of the person, the type of tumor. So we need to have a pathological or at least a cytological confirmation of the type of tumor, and also the date of birth and the gender of the person. That's the very minimum of information that we need to have. And also the place of residency, to know if the person belongs to that geographical region. Why is that important? That's the big, for many reasons. The first reason is to plan the healthcare systems. For example, in whatever a city that you can think of, to know how many oncologists you need, or how many beds, or how many machines to treat cancer, how many nurses you need. You need to estimate the number of patients today and in the years to come. And there is only one way to do that, is to understand what's happening now and in the past, and then you project to the future. So it's a very easy thing to do if you think that the crucial information you need is rather limited, is a handful of absolutely crucial variables. That's for what we call incidence, the occurrence of cancer. On the top of that, we also need information on mortality. So once a person gets cancer, within X years after that first diagnosis, is the person alive? Is the person dead? And if the person unfortunately died, is the death caused by cancer or by some other disease? And you need that coded and linked with the incidence data. This is also extremely important because that gives you a good opportunity to understand the quality, the speed of the system, the healthcare system, to respond to a cancer case, but also the quality of diagnosis and care. And this information is crucial because you can know if a country or a region or a city are doing better than another one. And then you can identify opportunities to improve diagnosis and care. So absolutely basic information and essential information. It's the same thing in any system, not only a healthcare system, but in any system, you need to know what are the numbers or how many people you are dealing with to be able to plan. So cancer registries are difficult to keep because they need trained personnel, they need sustainable financing, they need persistence, and they need political will. Without these elements, on a continuous basis, you don't have a cancer registry that lasts over many years. And the importance of the registry is its continuity. So only to have one-off information is not good enough. The importance of the registry is what we call the time trends. That means that we know what is the evolution of cancer over time. Why is that? Because cancer, the patterns of cancer, they change in populations. They change a lot. The total number of cases change, but also the types of cancer can change. New types can increase, other types can decrease, and also the system needs to adapt to that. So it's really is the continuity, the long-term cancer registries, which we lack most, in particular in low and middle-income countries. Usually because the support is not, a continuous support is not there.
Yeah, but I mean, it's not excruciatingly costly. I mean, if you have the political will to connect all the labs and all the hospitals and all the mortality, the people who register mortality cases and so on, I mean, these are just pathways. But like you said, just to have the system in place and the salaries of one or two people, right?
It depends on the complexity of the system. I mean, there are systems which are more complex than others, and then you need to adapt, of course, the number of staff working in registries accordingly. It's not as simple as just linking databases. You really need people specialized in cancer to understand the coding, to identify errors, and to be able to connect the dots and interpret them. So it's still, you need capacity, people who are trained to do the job. It's not just collecting data from different automated sources. Very few countries can do that. Most countries still need a lot of curation of the data that is indeed available from different sources, but they need to be compiled, put together, standardized, and analyzed and interpreted in a meaningful way.
Yes, I hear you. So basically you have basic versus sophisticated registries. So the basic is the one you described that only record incidence and type. But like you said, there are more advanced registries. Can you tell us more about that?
Yeah, there are many different cancer registries across the world. Just to cite China, for example, there are over 2,000 cancer registries in China, in one country, because it's a very large country. Other countries, let's say Norway, which is a country with a population of a little bit over 5 million, has only one national cancer registry. So it depends on the model, on the healthcare system in the country. The cancer registries can differ a lot. There are several cancer registries that register only the basic information, as we discussed before. Other registries opt to register, for example, treatment data and also quality of care, satisfaction of the patient, and satisfaction with the care and with the healthcare system. So it depends on the ambition, let's say, and on the capacity of the register to collect different types of information.
Fantastic. I mean, my goodness, to think that there are cancer registries who actually take satisfaction of the patient. I mean, that's huge. They must be super advanced to be able to touch upon this KPI. Amazing.
Yeah, but it's actually very important. It's what we call the PREMs and the PROMs. So it's the patient-reported outcome, and also is the patient perception and satisfaction with the system. And these are actually, and more we understand that this is absolutely crucial, because if you are a cancer patient, you are not a number. You are a human being with feelings, and what you want is not only to have a diagnosis and a chemotherapy or radiation therapy. You want to be cared for. And to care for a human being is much more complex than simply treating the tumor itself. You are treating a person, or you are caring for a person. And this is absolutely fundamental for the well-being of
that's amazing. How many countries do you think have these kind of advanced registries, just on the top of your head?
Yes, at country level, I know of a few. I think Scandinavia is leading that in many ways. Netherlands has tried it, Australia has tried, and there are regions in other countries that also are piloting or doing that. But it's increasing more and more. I think countries are becoming aware of the importance of not only care, but quality of care.
Yeah, I'm not surprised that the Scandinavians are on top of mind, because recently I read something about that they actually made an official, I think, rule for people who have burnout, that they officially need a holiday. So they're always one step ahead of the rest, aren't they? Amazing. But you as IARC, how are you then supporting low middle income countries through initiatives like your Global Initiative for Cancer Registry Development, GICR, which is IARC's flagship program and one of your most transformative? Can you explain to the audience sort of the real work on the ground that you are supporting LMICs to actually, to either start a cancer registry or to advance one?
Yes. So indeed, we have this program that we call the Global Initiative for Cancer Registration. This initiative aims to support cancer registry staff on the ground, to give training, basic training on cancer registration, on the techniques, on the coding, on the IT support that needed, and how to collect data, how to control the quality, how to standardize it, and so on and so forth. We have developed courses which are on our website. If people go on the IARC website, www.iarc.who.int, I will repeat, www.iarc.who.int. They will find the courses there. These are courses totally free of charge, and they are very pedagogical. So even for a country or a region which is starting a cancer registry, people can train themselves by using these modules to learn how to do cancer registration. So this is sort of the bread and butter of cancer registries that people need to know before they launch any initiative. We also give or make available for free softwares that allow cancer registries to get started, to collect information in a way that the coding is automatized or semi-automatized, and then there are corrections within the program, so to avoid illogical coding. For example, that a male would have been a coding for a cancer which is a female cancer, or vice versa. So this all is made available via the IARC website and the IARC resources. We also have courses that we give sometimes in different regions of the world and in different countries according to the needs. And then we have hubs of expertise in different regions of the world that also give one-to-one support to cancer registries when they have questions that they need an immediate answer to be able to advance their work. So it's a network. We are in many countries. In most countries, actually, we have collaborators in the cancer registries, so that we try as much as we possibly can to assist them to collect good quality data, but also to compile this data and send back to us so that we can compile data across the world, standardize them, and then put in an open source database which is available for everyone to consult and use freely.
Yeah. And so basically, any country who hasn't started one, they just have to connect with the IARC, and all the tools and support is there. It is absolutely there. And most importantly, I would like to repeat that, you know, you need a cancer registry to be able to fight cancer. It's as simple as that. Otherwise, you cannot do policies. You'll be working in the dark, so to speak. You need to know, you have to have the data to instill the policy and to start with your own priorities and so on and so forth. Cancer prevention is the most effective strategy for every country, and certainly the obvious for low and middle income countries who cannot screen or treat. And there are many countries who are, you know, not able to neither screen populations nor actually offer quality treatment. And that is why we have 70% mortality in low middle income countries. So prevention is the obvious choice, right? It's the first door that you can close against cancer before it goes in, right? It's like having a thief. If you close the outside door, it's easier to deal with the thief than letting the thief go in and create havoc and then deal with that person, right? So prevention is the smartest investment, and certainly you have spent your career championing prevention, whether in infection, lifestyle risks, environmental exposures, etc. Yet prevention remains chronically underfunded. Why is that?
Yes, indeed, I fully agree with all what you said. Prevention is indeed by far the most cost-effective investment any government can do in cancer. And it is undervalued. Probably because there are very few products that you can sell or money that you can make for industries or for private sector by doing preventative measures. I mean, for all the types of actions within the healthcare system, let's say treatment, chemotherapy or immunotherapy or other types of therapy, you can sell a product, right? A drug or a treatment, and there's a business to be made there. With prevention, usually there are no products, no commercial products that can make a business for someone. And that, of course, there's less interest than in investments, because usually governments want to see industries implemented in their own country, such as the pharmaceutical industry. So they tend more to look at the industry side, which has a direct impact of economy, tend to look at prevention. However, indeed, the way society is evolving now, unluckily that treatment is evolving, there are many new treatments and they are very costly. And the healthcare systems are feeling the pain of the costs of cancer treatment. And they are now starting to pay more attention to prevention, because they see that they can not only save lives, but also save funds and increase the GDP in their countries. But still, there's a long way to go to make governments and decision makers aware of the absolute necessity to prevent cancer at all levels. Otherwise, healthcare systems will be broken in a few years' time to the very high cost of healthcare.
Yeah, and especially, Dr. Elisabeth, now that we have precision medicine that is so costly, if they don't take preventative action seriously, yes, no health ministry in the world is going to be able to afford cancer care. So I agree with you there. And if you could choose only 3 prevention actions that could save the most lives globally, what would you choose?
Well, first is tobacco prevention. I mean, tobacco is by far the public health #1 enemy that we have for cancer and for several other non-communicable diseases, including cardiovascular diseases. So by far, the tobacco industry is the public enemy #1. Globally, it's a very large proportion of all cancers are directly related to tobacco consumption in all shapes and forms, smoked, but also chewed, used orally, and so on. And this is of particular concern now, because the tobacco industry is trying to find ways to engage new generations of young people, adolescents and young adults, to be addicted to nicotine with the new products, which are the electronic cigarettes, and also the pouches with the nicotine pouches that people use under the lip to get addicted to nicotine. So tobacco by far #1. Then infections. I mean, a large proportion of cancers are caused by infections, in particularly HPV infection, human papillomavirus, for which we have now a vaccination which is highly effective, and it's recommended to all adolescents across the world, in particularly for girls. So I think this would be the 2 first important things to do. Then #3, it varies by region of the world. In many parts of the world, physical inactivity and obesity are increasing dramatically, and they are directly associated with a large proportion of cancer incidence and mortality. And in other regions of the world is alcohol consumption. So I think at this, let's say diet, nutrition, and alcohol consumption all put in one package, it would be number 3. So tobacco, infections, and diet, nutrition, and alcohol consumption.
And reflecting on your background in breast and cervical cancer epidemiology, you pushed for strengthening research partnerships to reduce global disparities in women's cancer outcomes. So, starting with HPV, because we've just touched on it, IARC played a pivotal role in the evidence base that led to global cervical cancer elimination strategies. Please tell us about that.
Yes, so cervical cancer is a very important public health program in many regions of the world, and in particular in sub-Saharan Africa, where there's a concentration of incident cases and deaths. In other parts of the world, like in North America, in Europe, and in many Arab countries, the incidence is much lower. So the aim of WHO and IARC is to reduce globally the incidence to very low levels, to levels of below 4 per 100,000 women per year. And to do that, there is one strategy, one key strategy is vaccination of teenager girls. And why teenager girls? Because there is a window of response, immune response to the vaccine, which is ideal, let's say between 9 and 13 years of age. So if you vaccinate girls against human papillomavirus or HPV in that window of age, their immune response, their antibody production is optimal. So, and we know, and we have demonstrated this in several studies done by yourselves, but also other researchers now have started to publish, that the protection for HPV can last for many years after at least one dose of the vaccine. And if we would increase vaccination rates, let's say to 80% of all girls worldwide, we would eliminate cervical cancer, basically altogether from the face of the world within this century. And this would be something unique in the history of humankind, that we could almost decrease to zero a cancer type worldwide. So it's in a way is a historical period that we are living, where we have this technical possibility to eliminate a cancer. This has never been done before. IARC has been indeed instrumental in the whole history, in this beautiful history of discovering the virus, of understanding the distribution of the virus in different populations worldwide, different subpopulations worldwide. And then to help to test the vaccine in different populations, to compare the number of doses of vaccines, to find the ideal age when the vaccine should be applied to the populations, and also to follow up, to look at potential side effects, and to calculate how many years or decades would it take for each country to eliminate cervical cancer as a public health problem. So yes, we still do a lot of research, and we will continue to do a lot of research on human papillomavirus. It's a priority for us because there's such a large proportion of all cancers which are due to this virus.
But Dr. Elisabeth, you say the optimal window between 9 and 13, and that's evidence-based. But if one missed that window, can they not be inoculated at age 25 or 35?
Yes. So the immune response is ideal within those ages. But yes, there is some countries and in some regions within countries are offering what they call catch-up strategy to vaccinate women, even if they have lost to be vaccinated in this age window, that they can be vaccinated, ideally before age 26. Because above that, the immune response is less optimal. So the older you are, the worse is your immune response. So and also if you vaccinate before that age, we don't have studies on that yet, which would recommend vaccinating before very young girls. So the ideal is at early adolescence, but not above a certain age, because then the immune response is so small that it's not cost effective.
And what are the side effects mainly?
Well, as any medical product, there can always be side effects. For the HPV vaccine, is a very safe vaccine. Is one of the safest vaccines that humankind has ever produced. And there can be effects such as the arm getting a little bit red or get a little bit painful in the place of the injection. There are some girls that have very rarely have syncopes, that mean they have had a reaction for different reasons, that they have lost consciousness, but for a very limited period of time. But basically, they are extremely rare side effects, extremely rare. And the benefits of the vaccination at population level are far higher than the potential side effects.
I'm glad our audience managed to hear all of this, because there is more awareness now, but not as much. But I want to focus on the fact and really give credit to IARC for playing a major role in generating evidence behind the single dose of HPV vaccine, because that has huge implications for this, helping countries to actually afford the vaccine, right? Tell us more about that. I mean, it's a big difference of having to do 2 doses as opposed to single dose. Tell us more about the benefits for this finding.
Yes. Also, to have everyone on the same page. So the vaccines, the HPV vaccines, when they were launched in the market, and this now is about 20 years back, the advice was 3 doses of vaccines with an interval of several months between each dose. What IARC put in place were studies, in particular in India, comparing the effect of 1 dose, 2 doses, and 3 doses. And what we observed, and this was published already a few years back, is that the seroconversion or the immune response was very similar when girls were vaccinated in this ideal time window that I mentioned before, if you have 1, 2, or 3 doses of the vaccine. This same observation was now replicated in another large study in Costa Rica, which was done in collaboration with the NCI and IARC. So now we have enough evidence from these 2 very large studies, plus other smaller studies published by other groups, indicating that 1 dose might be enough up to at least 10 years after the vaccination. And of course, 1 dose is cheaper than 2 doses or 3 doses, not only because of the price, but also because it increases the availability of doses to be used to a larger proportion of the population, because there is, up to now, an important deficit in the production, in the sheer number of doses of vaccines produced worldwide. So it has been difficult for some countries to assess vaccination in sufficient quantities to cover the whole population. So indeed, I think these studies comparing the doses, and now the SAGE, there is a committee at WHO that had before recommended that 1 dose can be used off-label for population-based vaccination campaigns. Several countries have already adopted the 1 dose strategy. For example, India itself, Brazil has done so, the UK, and several other countries now are considering changing the recommendation for 1 dose for the ideal age window or when immune response is optimal.
Fantastic. I mean, this is great news, certainly. Now I want to talk about the IARC monographs. The IARC monographs are often called the Supreme Court of Carcinogenic Evidence. It's a gold standard scientific program for over 50 years that identifies carcinogenic hazards to humans. Can you please explain to the audience what are the IARC monographs?
So the IARC monographs on carcinogenicity to humans, it's a program at IARC, is a group of scientists at IARC that have 50 years ago already developed a methodology to evaluate all the publications in animal models in experimental models like Petri dish before, but now there are other experimental types of models, and also studies in humans on specific exposures and their capacity of inducing cancer. Traditionally, most chemical substances were evaluated in this program. I mean, we are surrounded by chemical substances in our food, in air pollution, in any object that you touch. Basically, it's a mixture of chemical substances and chemical processes using in industry, in healthcare, and so on. So far, we have IARC has evaluated over 1,000 substances that are potentially carcinogenic to humans, and over 100 of those have been identified as directly causing cancer and therefore justifying very strict measures of exposures, for example, among workers dealing with these substances. So the methodology is such that first all the published literature is identified, then it's classified according to its quality, its reliability, in terms of animal models, experimental models, or studies in humans, and then with a set methodology, tables are constructed, abstracting the results from each of these studies, and they can be hundreds of studies from a single substance. And then there is a group of experts, usually is the top experts around the world on a specific topic matter, and these people get together for 10 days, and they scrutinize each and every study, and they discuss in depth the possibility that this particular substance can or not cause cancer in animal models, and in humans. And they reach a conclusion, which a classification: is the substance a potential carcinogen to human, a possible carcinogen to human, or it is certainly a carcinogenic substance to humans. This classification is then used by many countries to consider which potential dose of that substance can or not be accepted within each country. For example, in occupational settings, in healthcare settings, in food, in water, and so on.
Yeah, and you know, the classifications they have, for example, group 1, it says, you know, it's carcinogenic to humans, clear evidence like tobacco, asbestos, HPV, alcohol, solar radiation, etc. Then you have something like group 2A, probably carcinogenic to humans, strong but not conclusive, like very hot beverages, which I don't understand. I mean, we're always boiling the kettle, aren't we? Surely,
Yes.
when we're drinking tea every time, I mean,
Yeah.
aren't we drinking above 65 degrees? Please
Yeah.
explain that.
Yeah. So as you said, so group 1 of the monographs of carcinogenicity to human, group 1 substances are the substances that there is plenty of evidence that they cause cancer. You mentioned tobacco, you mentioned asbestos. This we know. If, for example, if a person is exposed to asbestos systematically, there is a very high chance that that person will develop sooner or later a tumor in the lung, which is very fatal. It's called mesothelioma. And that we know. We have observed this over and over again across the world. There is no doubt that that particular substance causes a specific type of cancer. And then the countries are, of course, invited to consider legislation banning the substance entirely or controlling as much as possible their exposure. For other types of exposure, you mentioned hot drinks. There is evidence. The evidence for hot drinks comes mostly for esophageal cancer and from some regions of the world where tea are drinked very, very hot. And the evidence comes mostly from South America, where people drink a green tea, which is called mate or chimarrão, extremely hot, close to 100 degrees. And then they cause a chronic burning of the esophageal lining, and that has been associated with esophageal cancer. So is the tea that you drink and that really burns your lips and burns your esophagus. And if you drink that over several years, the chance that you get transformation or on your esophageal cells is extremely high. So it's the burning.
Yes.
The cut point is above 65. The recommendation is to avoid any foods or drinks which are above that temperature because there's a burning of the mucosa. And this
Sorry,
this
continue.
has also been demonstrated in animal models very, very clearly. So the eating or swallowing hot foods or beverages, in experimental animals, it very clearly increases the risk of carcinogenicity of the esophageal mucosa.
I drink a lot of tea and coffee. Next time I'm going to put a thermometer. I mean, of course, I do wait a bit after the kettle boils, but it'll be interesting to see on what temperature am I drinking that, because I don't think many people know about this, and I was certainly very surprised. But also I was surprised, you possibly carcinogenic to humans, mobile phone, radio frequency exposure. I mean, so it's still not conclusive that all this mobile radiation affecting us in any way, and now with the new specialized headphones and all of that?
Yeah, no, I will not comment specifically on the mobile phones, but in general, in the monographs, this classification is about the amount of studies indicating carcinogenicity. So in group 1 indicates there is plenty of evidence of carcinogenicity.
Yes.
So we know it causes cancer. For the probably carcinogenic to humans, that means there is some evidence which is substantial, indicating that the substance causes cancer. And the third category, the group 3, is that there are some studies, but these studies have many pitfalls and they are not enough to be conclusive. So then there are some indication, but not enough. So we still need more high-quality studies to reach a conclusion.
And then, of course, I see in group 1 also you have something like processed meats. I mean, that's conclusive. I mean, high likelihood of being a cancerous hazard.
Yeah.
And then you think about a country like Germany, the sausages and the processed meats, and even Italy, you have a lot of processed meats. Surely, yes. And so they know about this and yet turn a blind eye somehow. Interesting. But I also want to focus on tobacco-related products because, like you said earlier as well, this doesn't just include traditional cigarettes, but secondhand smoke, smokeless tobacco, the areca nut, the betel, etc. But how come we never heard IARC scream and shout about the new electronic cigarettes, the fact that they are in group 1, carcinogenic, is such a difficult name to pronounce, to humans?
Yeah.
Why is it? And also, why alcohol? Somehow alcohol doesn't get the same stigma as that of smoking, right?
Yeah.
It doesn't. Why is that?
Yeah, so for alcohol, IARC has published 3 monographs, and I was the author of a co-author of one of them. So there is plenty of evidence of carcinogenicity. There is no doubt alcohol is carcinogenic to humans, and the more a person is exposed to alcohol or drink, the higher the risk of cancer. As you said, people are not entirely conscious about that. If you ask anyone in the street what causes cancer, most people will identify tobacco as a cause of cancer, but not many other substances. And many people will not identify alcohol as a potential source of cancer, of causing cancer. And actually, many people will think, particularly in Western countries, that alcohol is beneficial for health, particularly for cardiovascular health. It is not. It's a myth. The best conducted studies, the large studies, don't indicate any benefit of alcohol to cardiovascular disease either. So, particularly in Western countries, alcohol is directly associated with breast cancer. Actually, it's about 10% of all breast cancers in women that in Western countries that probably are due to directly related to alcohol consumption. So it's a lot, because breast cancer is a very common cancer. in Europe, North America, etc. Why is it not more talked about? We try to do our best to disseminate the information, but there is a lot of lobbying against it. And it's, I mean, lobbying of the tobacco industry is known by many people, that there are many strategies implemented by the tobacco industry to create confusion, to say, oh no, there is not enough evidence, or we need more studies, etc., or you can use light cigarettes or menthol cigarettes or whatever, which is sort of, it's not correct. All tobacco causes cancer. But for alcohol, the industry has been very good in counter-arguing, in particular because there's a huge interest by countries with the alcohol industry. It's a big business in many, many countries. I mean, IARC'S based in France, and France is one of the countries where the alcohol industry is extremely powerful in all of Europe, but also in Australia, in New Zealand, in Argentina, in the US. So it's a very powerful, a very rich industry with a lot of means to combat information. About electronic cigarettes, so IARC wishes to make an evaluation, a Monographs evaluation of electronic cigarettes and other smokeless tobaccos which are used in these new systems. But we have not yet done it. We would like to do it in the next few years. It will not be this year for sure, but we would like to do it in the next few years. The Monographs program at IARC currently is unclear if it's going to continue because of the budget crisis, which you certainly are aware of, given
Yes.
the unclear position of the United States regarding the support of science, and in particular science at IARC. So we are hoping that the US will take the good decision to keep supporting science, because this is in the interest of Americans and the American people, for sure. It's very clear. But it's not, we don't know yet what will happen with the Monographs program. And the evaluation of these products that we just discussed, the new tobacco-related products are in our list to be evaluated, but we don't know if we will be able to evaluate it due to the budget crisis.
I mean, this is crazy. There is so much money suddenly appearing when there's a war to be had, but no money when you need it for science, for cancer, for research. It's really absolutely crazy. I sincerely hope that the powers to be, whoever they are, they reconsider and support the one agency that's absolutely objective, neutral, and science evidence-based, that's informing the whole world about causes of cancer, prevention, and so on. But I wanted to ask you, when we talked about industry always pushing back, whenever you come across or you want to announce a new chemical or item on the list of the monographs, how does pushback happen usually? Is it you have protests outside IR? Do you have personal threats? Do you have media spreading misinformation? How does that happen normally?
It's a combination of all this. So these industries, they are very sophisticated in the way they push back scientific information. And the guideline has been developed by the tobacco industry over many decades. And this is very well documented in several books, their strategy, how they systematically contradict science to push their products to the market. The same techniques used by the tobacco industry are replicated, ipsis literal, copy and paste, to the alcohol industry and also to other industries. For example, several companies doing foods, ultra-processed foods, use the same misinformation. And also for several chemical products, pesticides, herbicides, we have seen similar strategies. Basically, the strategy is to discredit the scientists or the agencies producing the science in different ways, which can be very, very obviously untrue, but very hurtful for organizations and for people, is to say that there is not enough evidence or the evidence is not sufficiently solid, and so on and so forth. So these are very well-known techniques, and they are usually very well supported by very large budgets within these industries, in particular the alcohol industry and the tobacco industry, but also other industries have whole groups of people that are employed to discredit science.
Yeah. And I think, that's their typical modus operandi, is that when they want to kill the message, they go after the messenger.
Absolutely.
So they do that. But this brings me to the fact, in general, health has always been health awareness, shall we say, or the work of, let's say, WHO, is really always limited to conference rooms. We're always talking to each other, to the choir, so to speak. And now that we have, like, for example, until I think it was 10 years ago, I visited IARC, and I was talking to Dr. Chris at the time, and then he was telling me about the monograph. First thing I said, how come we don't know about this? How come the public doesn't know enough about IARC? So I'm thinking, in terms of course, the industry has a field day to push back because the public doesn't know about what you are doing. And so do you think platforms like OncoDaily and other oncology-focused media that help transform the message into more layman, into the layman sphere, shall we say, could help IR communicate its findings more clearly and effectively to the public? Because, for example, OncoDaily, and this is not a marketing tool for OncoDaily, but this has been a recent sort of media platform that has democratized, so to speak, the message. It has clinicians, cancer advocates, researchers, policy actors, patient groups across every region, especially in LMIC, the very regions IARC wants to empower. And even organizations like UICC, they have the same cohort of actors. Is there a way to improve this so that you can have more proactive communication, so that IARC can shift from being defensive to actually leading the narrative, etc.? Because people need to know about what you do. Like even maybe this podcast. I know it's a small podcast right now, but I might reach some people who will now know about what IARC does and about the monographs and so on. Please tell me a bit about that.
Yes, the more the better. Yes, communicate. As a scientific organization, of course, our main way of communicating is scientific products, which is they are targeting the scientific community. But we are trying more and more to reach more to policymakers and to the public in general when the messages are sufficiently mature to go to the public. The scientific process is a slow process. It's a process where you accumulate over years the knowledge about the topic. And usually we should only go to the public when we have sufficient knowledge for a very clear message. And this is only the tip of the iceberg, because 99% of the work is the silent scientific work that goes behind one information that goes out to everyone. But yes, the more we can disseminate the importance of the work, the better, by all means. And in particularly in what I mentioned to you, that the monographs are in a risk not to have their financial support continue because of the withdrawal or the lack of engagement, or the potential lack of engagement of one particular state. It's very important that community is aware that there is an acute need of supporting of a program which is absolutely essential for public health. And so that might be people listening to this podcast or to other information on OncoDaily or other means that help us to find solutions to keep these essential programs alive.
Because if IARC doesn't do the monographs, who would do it?
Nobody.
Nobody.
There are no other organizations which are free from vested interest from the industry today that can do this work. There is simply no one that can do what we can do.
So basically, if the monographs are not done anymore, industry will have a field day to put all kinds of chemicals in our food, in our air, in our daily life without anybody pointing the fingers. This is crazy.
Yeah.
So yeah, but I really would love IARC to really think about ways how they can increase communication to the public, because then the public can become your voice to push back.
Yeah.
So certainly, something to think about, because otherwise your amazing science is just filed in cupboards, and the public don't know about this. Under your leadership, Dr. Elisabeth, IARC shifted towards implementation science. And I love that, looking at how cancer interventions actually work in real life world health systems, from cervical cancer elimination to breast cancer early detection in LMICs. How is this helping countries and policymakers turn scientific evidence into practical cancer control programs that truly work on the ground? And if you can give me an example, how is a scientific organization like IARC, how did you sort of work to turn it into implementation science? Can you give me a real life example?
Yes, so yes, absolutely. So again, let's turn back to the HPV history. I mean, HPV, the human papillomavirus, that can be prevented by vaccination, but it can also be detected in women infected in the uterus, in the opening of the uterus of women already infected. And that if you detect virus there, you can use it as a tool of screening. And it's a very effective tool of screening. That means women that have not been vaccinated, they need to be screened. Women that were already too old when the vaccine became available. And usually in many countries, the detection of cervical cancer, which is the cancer most common cancer caused by human papillomavirus, was done by cytology. Cytology means that you collect cells from a tissue and you look them under a microscope. It's a very cumbersome test to do. It's a very difficult test to do, and the error is enormous because simply you miss the cell that you should look, or you don't look exactly in the part of the microscope that you should look. So there are many possibilities of error. So the error in most cytologic-based programs can be up to 50%. 50% error is like tossing a coin, head or tail. So it's huge. It's absolutely huge. So the HPV test is much more precise because the error is extremely small. It's in some settings, it's less than 1% error if the virus is present or not. So testing for the presence of virus in the cervix of women is much more effective HPV testing. Therefore, several countries are swapping altogether from cytology to HPV testing. And IARC is actively working with several countries in this swap from one test to another, helping them to find the right setting, implement the technique, and help to evaluate the quality of the test, and then to scale up to large populations. So starting small, implementing all the techniques, and then scale up. We are in particular working with the government of Brazil in the north part of the country, where there's a lot of infection with HPV and cervical cancer, to do this swap between the cytology, currently the standard of care, to HPV testing. And once this is implemented in one state of Brazil, the idea is, together with the Ministry of Health, to expand stepwise to the whole country.
Amazing. I mean, it's so important, this shift to implementation science, because that's where the real work happens. You were also instrumental in shifting the relationship with low middle income countries from research done on LMICs to research done with LMICs. How is IARC working to ensure that scientists in Africa, the Middle East, and Asia are equal partners and not merely data sources? And what sustainable programs did you establish to forward IARC's goal for equitable global cancer research ecosystems?
Absolutely. This is so important, Dina, because I mean, for decades, I think many organizations, universities, research centers were always going to collect data around the world and then bring this data back to their own organizations, analyze, publish, and then have a sort of a line in the manuscript, maybe thanking the people that donated the samples, let's say. And this is not acceptable anymore. I think it's a form of colonialism that we all want to get as far away as we possibly can. So IARC, most of IARC projects done at IARC are done in partnership and constructed with colleagues in all over the world, in different countries and different settings. And basically all our publications reflect that, the inclusion of colleagues from different countries among the key authors of each and every article. And this is, of course, is open access, and you can verify this in most publications of IARC. IARC has also a program of training of human resources for research. We have a school for researchers. It's usually 3 weeks every second year that people can get engaged. It's like a master program in cancer research. And there are 3 intensive weeks usually at IARC, but they have to study home with modules for learning how to do cancer research. IARC has also now launched a research school together with Chinese colleagues in Beijing. We are launching one in Brazil with the National Institute of Cancer and several universities, mostly with the University of São Paulo, and we are discussing with the Saudi Arabia to hopefully do one also in the Middle East. And we are open to other initiatives. But I mean, to train the next generation of researchers is crucial. And not only researchers that can do research at the national level, but that can be partners in international collaborations. Because most cancer challenges are common across countries. So problems that you see in Jordania are also similar to problems in Egypt, in China, and elsewhere. So there's a lot to learn by international collaboration.
Absolutely. I mean, and this brings me to the future, where now it's big data, genomics, exposomic data, now dominated by high-income populations. And what risks does this pose for scientific equity? And how is IARC working to ensure that low and middle income populations are not left behind in the era of precision oncologies, where we are totally not represented?
Yeah. There is a lot of enthusiasm, of course, about precision oncology, with reason, because for some cancer types and some particularly characteristics of some tumors and some patients, there is room for what we call precision medicine. However, for many countries in the world, still the challenge is just to have a healthcare system which is sustainable and that produces healthcare of good quality at all levels. And this is something that I think is, for us at IARC, is a top priority. We do have a very good research group that works with healthcare systems, trying to look at the whole sequence of events in a healthcare system that need to be in place to prevent, detect early, treat and follow up patients before they get cancer and throughout their cancer journey. So I think the enthusiasm with precision medicine is to some extent driven by technology. So there are new technologies, new way to genotype patients and also to use let's call fancy drugs, which many times are justified, but not always. Sometimes the new drugs don't really add much to the quality of life, to the duration of life, with exceptions. Some do add a lot. For example, in melanoma, there is a tremendous improvement in multiple myeloma, etc., but not always. So I think what IARC does in a way is to bring this discussion to levels that people can understand what this is about, what are the implications, and also to have discussions with colleagues in healthcare systems to see, are the systems ready for this new technology, so that they are not just adopted without understanding the consequences, budgetary consequences, but also the complexities that they imply. And if you invest in one area, you cannot invest in another area. So to discuss with decision makers which are the choices that need to be made to give benefit to most of the population.
Yeah, not to the few, exactly. And I have two more questions for you, but one we've already touched upon, which is the financial sustainability for such an organization such as IARC. What can you do? How do you get more funds? Do you visit countries and talk to them about IARC, those who are not members? How are you able to sustain the financial resistance that is so critical for an institution like IARC?
Yes, so we definitely are trying to recruit new countries to be part of IARC. And then in the region where you come from, in the Middle East, I mean, we would love to have more Middle East countries joining IARC. Currently, we do have leadership countries such as Saudi Arabia and Qatar and Egypt, which are already members, also Morocco. But we would like to have other Middle East countries joining IARC. And I think the United Arab Emirates, Kuwait, Oman would be, Bahrain would be obvious countries that could and should join IARC. And it would be wonderful to have more discussions with these countries and to have them joining IARC as soon as possible. We also have discussions with other countries around the world. In Europe, for example, we are in discussions with Poland. It's a country that we would very much like to join IARC as soon as possible. In Latin America, we are in discussions with Mexico, which also we think that's a country which is ready to join IARC. But there are many other countries across the world. Kazakhstan, for example, in Asia, we think it's already mature enough to join IARC. Indonesia, Philippines, there are many candidates. So we are in dialogue with these countries. But also because you, Dina, you meet so many decision makers, it would be wonderful to have your help to approach countries and to mediate the dialogue, to make them aware.
I am more than ready. In fact, there's a big conference in Abu Dhabi in April, early April. And immediately when you were talking about this, immediately it came to mind to start that conversation. And I'm happy to talk to the powers to be there and to connect you with them. I mean, this is so important. IARC is so important for humanity, full stop. We need such an evidence-based institution that is neutral, objective, ethical, to remain. And I know that IARC is turning 60 years this May. So we all need to work together to help IARC turn another 60 years. Yes. It's a remarkable milestone for a global institution such as IARC, and we certainly want to keep it longer. So what are you planning to mark this anniversary? How do you hope it will reflect IARC's legacy and vision for the future?
Yes, thank you for asking this question. So yes, indeed, the celebration of the 6th anniversary is a one-year celebration, which started last May with different scientific colloquia, seminarios, symposium, a lot of focus on our young scientists and the science that they produce. And now we are ending the celebration with a 3-day scientific conference. So we have 1,300 abstracts that have been submitted. And we are this week now, as we speak, there's a group next door to me evaluating the abstracts submitted and classifying them according to posters, oral sessions, and discussions. So it will be a scientific festival where we are going to discuss mostly cancer prevention, what do we know about cancer etiology, what do we know about cancer prevention, and which are the new studies that need to be done in the future also in the field of cancer prevention. So it's going to be a scientific fest in a way, a scientific festival. And it's going to be in May this year, 19th to 21st of May. And of course, the main target is the scientific community, in particular the young scientists in different countries. But it's open to whoever wants to participate. We are hoping to have also a part for the public in general. It will mainly the French public, of course, because these are local people that will participate. But we are aiming to have that to sort of a summary of the highlights of the conference to the general public on the last day.
But I also think, Dr. Elisabeth, why don't you choose this time to get your communication team to have certain messages? It's great that it's a scientific fest. That's fantastic. But, get them to work with UICC, OncoDaily, other organizations, influencers, so that we can just amplify certain messages that you have. People will be very willing to do that at no cost. Maybe you could think about that, because we don't want your messages always being hidden, and it's too important for it to be hidden. So maybe get them to work with all the organizations that you work with, that we can amplify your message. It's as simple as sending emails to all of us and say, please reshare those messages. Can you imagine the impact this would have? Please do that. Think about that, because we need IARC to turn 100 years, 150 years, and so on. And without the public's knowledge, you will never have the pushback pressure that you would have when the public know about the importance of your role. I hope you will take this comment seriously and see what you can do about that.
Certainly. Yeah.
Dr. Elisabeth, honestly, it's been a wonderful conversation, honestly. And thank you for your leadership and your service to global cancer control. And thank you for this truly enriching conversation. I am sure our audience learned a lot and they enjoyed it, because I certainly did. Your work reinforces a simple truth: when science is strong, evidence is clear, and equity is prioritized, lives are saved. Thank you for all that you do. And I look forward to seeing you, I think, in April, right? Are you going back to Cairo in April?
Yes, I hope so. I really hope so.
I hope so. So we meet again soon. Thank you so much. And I look forward to seeing you again in person. Thank you. Thank you very much.
Thank you, Princess Dina. Goodbye.
Thank you.